Thank you all so much for joining us today for Dr. Manish Kumar's dissertation presentation. Manish successfully defended his dissertation on December 14th, 2020, and we're so excited to have him here giving that presentation to us today. He is currently leading technical assistance, research, monitoring, and evaluation, implementation, and capacity building activities related to global health informatics while collaborating with the Regan Street Institute, University of Washington, and Intellisoft Inc. He is collaborating with the World Health Organization, UNICEF, USAID, World Bank, and other organizations for his global digital maternity model research work. Manish, thank you so much for giving your presentation with us today, and I'm going to turn the floor over to you.
Thank you, Lindsay. Thank you, everyone, for joining. If you can hear me clearly, please say yes.
Yes, you sound great.
Okay, thank you. So I'll share about my PhD research that I defended in December. And as we go ahead, please feel free to ask questions on the way. If you want to hold your question towards the end, that's also fine. And I assume that you will have that much of patience. Otherwise, let's start. So my research was focused on, so it's a case study research focused in India, focusing on a state tertiary care hospital. And the primary purpose was to understand the health information exchange, especially the inter-organizational health information exchange across different levels of the healthcare system, and bringing a focus within maternal health service delivery and program. So that's where the primary focus was, and what it takes to establish the inter-organizational health information exchange. So this is an outline, and I'll explain it as we move forward. So you'll see what the main problem statement that I just briefly mentioned. And this work is, is very important, not only in the context of the country where it was conducted, but also globally. And then also showing what theoretical frameworks are available that are being used, which one was more appropriate for this study, and going into the methodology. And towards the second part of the presentation, I'll focus more on the findings, and I'll share a lot of insights from the finding, but of course, it will still be a summary, and the details are in the dissertation, and then try to interpret what that means for some of the research that is happening currently, what it means in that country context, what are the recommendations that came from this study, and I would also share now, based on my experience, that how they are relevant for many countries that are working. That does not mean that this study findings can be applied as such in those country contexts, but some of the recommendations are applicable given how they touch on the different facets of the health system. And finally, it will be strength and limitation. Of course, when we talk about methodology, we'll see there are certain limitations that this study has. So the findings needs to be interpreted in that context, and also highlighting what are some of the future directions are available or that I plan to pursue based on this research. So that's an outline. These are the terms that have been used, national and subnational. They have different meaning in different country contexts, but primarily they refer to the administrative structure that is available in a country. For example, in US, we'll have federal, state, counties. There are many countries in Africa which have the similar structure. In other countries, we will have federal, state, district, and sub-districts. So that's what it means by national and subnational levels. Electronic health records for this purpose, you'll see the definition that is being used here. And health data exchange, I think it's important to understand this is about sharing of data across organizational boundaries, and not necessarily refers to the health information exchange the way it's interpreted in US and some of the other Western countries. Stakeholders, we'll explain more about this also as I move forward. And while this is talking about inter-organizational health data exchange, within the domain of maternal health service, right from ANC to PNC, so that's the spectrum of And there are several studies which show that one of the essential criteria for health information exchange, especially electronic health information exchange at the scale that countries are trying to achieve, it's important to capture electronic health information. And the data exchange that will be enabled through electronic health capturing can allow not only the capture and use at the point of care, but also at the different levels of the healthcare system. And the same data that is captured through the patient interactions has multiple uses. In certain contexts, they are referred to as secondary use of the data, but depending upon the purpose and the decision making, it's not necessarily a secondary use, but that might be primary use, for example, for monitoring and evaluation. Despite the benefits that can come with health data exchange within the organization, but also across organizations, there are studies that shows that the capacity is very limited within the low and middle income countries, especially, but also in many of the higher income countries. And there was a study published by European Union for 21 countries that they looked at. And there is also very limited information available when it comes to how to enable health data exchange across different levels of the healthcare system within a country, but also across countries, and not only from the clinical perspective, but where the public and population health perspectives are also integrated. There has been a lot of work in progress, so we'll see how that has informed this work. And a comprehensive survey of literature that was conducted to guide this research included, policy and program documents from many countries, and also reaching out to different organizations which are working in this domain to make sure that any good literature policy document that is not publicly available was at least made accessible to me for the purpose of this research. And that has been published in 2 of the journal papers. So those journal papers have details about the survey of literature and what came up. And I'll provide a summary here. So given that context, the problem that still exists is most of the health data that is generated is through patient interaction. Whether it's high income or low income countries, that primary point of interaction where patients interact with providers is where the data is generated. Now, how that data is captured, stored, and then shared influences whether we can really use and reuse that data, not only for care delivery, but also for program management and other purposes. And in order to make that data available for primary from the patient care, but also for program and population health purposes, it's very important to understand who are the stakeholders, what their information needs are, what data systems they are using at the different levels, how the data flows within a level, but also across the levels. To resolve that problem, an appropriate solution will be, to have a interorganizational health data exchange. And interorganizational can mean different meanings. So here in this context, it's the Ministry of Health, their different units sharing data with each other, but also different ministries within the country helping data with each other. And there can be organizations across countries as well. But this one is very much focused within a country context. In terms of significance, this is one of a kind study in India, and especially given that the National Digital Health Mission that India has initiated is not very old. There has been work related to digital health, but not necessarily in the concept of federated architecture that is proposed in the National Digital Health Mission. So it also contributes to the research knowledge base, and there are studies, but like I said earlier, there are not so many when it comes to establishing the interorganizational data exchange. There are studies on architectures, technical architectures. There are many, many policy documents that are available. And another important significance is that, at least it initiated in the context where this was conducted, a model available for researchers to critique, to review, to modify, and to improve, or at least to guide future research. So those are some of the significance of this study. The 2 important conceptual or theoretical frameworks that were used. So this is a framework that has been largely used in the low-income countries. It's called the Performance of Routine Information System Management Framework. And what is interesting and useful about it is it looks health information system from a socio-technical perspective, looking at the technical factors, whether it's a design or IT aspects, organizational factors, where you look at governance, planning, quality, supervision, but also the culture of information sharing and use. And the behavioral factors that have significant influence on how the health information system processes works or get performed by the individuals who work in that system has an influence on data quality and data use, which ultimately contribute to the improved health system performance or health status. So this is the framework that has been applied in many countries' contexts. But I think it's also important to highlight here that this is largely has been applied in the aggregate data context, not necessarily in the clinical setting, but the socio-technical aspect is what is very relevant for the purpose of this research study. Another important framework that was relevant for this work is the socio-technical model from Dean and sitting at the in Texas. They've come up with the model which looks into HIT implementation in the complex adaptive healthcare system. And this is very much in the clinical care setting. So you can see that this model is very much in the clinical context, but in the context of US or the developed country context, whereas the earlier framework was on the aggregated system, but in the context of low-income countries. So these two frameworks, they both take the socio-technical approach, so that's the relevant part, and they both address a specific aspects of the healthcare system, one in the clinical, other one more on the low-income country context. So that's how together these two frameworks are used for the purpose of this study. And this influenced how the data collection tool was designed, what questions were included. So they influenced the development of the tool. When it comes to methodology, as I mentioned earlier, it's a single case study research, and the main aim was to identify factors that hamper development or support development of EHRs, which are important to enable health data exchange. And within that aim, there was a specific research question that you can see here, looking at drivers and barriers, both from the design, implementation, and the implementation side. So that's how the questions were framed. So this was the first aim. The second aim was to understand, like I mentioned earlier, it's very important to understand who the stakeholders are, what their information needs are, what data systems and workflows already exist. And to understand that aim, there were three research questions, looking at the stakeholders, their data needs, and also understanding the systems and processes that were in place to support decision making. And the third aim was based on the first two, suggest or propose a health data exchange model. And to serve that aim, one of the important questions, what are the essential design and development requirements that the stakeholders considered as important to be included in a health data exchange? And then also to showcase how will that model really enable the decision making, both from the program management perspective, but also service delivery at a hospital, state, and the national level. So in the context of the federated architecture that the digital health mission has, there are three levels primarily. One is facility, state, and national level. Now, facility will be primarily where the services are being delivered, and they can be of different types. But those will be the three essential levels to enable health data exchange in a federated system. So those were the research aims. A single case study, primarily to provide a holistic and contextual view, because this is one of its kind studies. So it's important to understand how the context of the research setting influences the work. But also if the focus is to understand the socio-technical aspect, then the case study design was an appropriate one. And it also aligns well with the time and financial constraint that existed for this study, especially when the study was designed, the COVID didn't exist, but once I started working on, it happened. So I would not say that I was wise enough or I had the wisdom to choose this study because it will become feasible, but it became useful and feasible in that constraint as well. And then this was conducted in a tertiary care hospital setting, which is one of the tertiary care hospital in the state of Uttarakhand in India. And here's the map that you can see where that state is and where that hospital is. Now, it's a tertiary care hospital. It's a government hospital. In general, we can say that government hospital will have similarity, but depending upon which part of the country you go, and there will be wide variation in terms of their capacity, both in infrastructure, the leadership, the workforce, skill set, their coverage, the type of services they provide. So there is a variation, but still there is certain minimum standard that is hospitals are expected to have based on their accreditation. So you can have a baseline or benchmarking that will apply to this tertiary care hospitals. So how was the data collection conducted? Of course, looking at all the policy documents, reports, registers, and forms that were available from both national, state, and the subnational levels. Key informant interviews was the primary way of collecting data, and what it focused on, like I mentioned earlier, to understand what stakeholders thought or had opinions about the barriers or the factors that supported data exchange, but also the role and responsibilities they have within their organization and the health system, what health information they required for different types of decision making, and the systems that were used in different organizations or different levels to collect, store, and share data for decision making. And also they provided input in terms of what were some of the essential design requirements from their perspective that will enable to perform the task that they were required to perform within the healthcare system. And it was a virtual data collection that happened between April and July. And initially the plan was to conduct in person, but given the travel limit restrictions, it was virtual data collection that was used. From the sampling perspective, keeping in mind, it's a case study with a very specific focus. The purposive sampling was conducted, and this was based on the setting, the focus, the research questions that were there, identifying at what level the respondents will be selected. As you can see, there were 20 key informants selected. And many of these individuals have multiple roles. So for example, one person will be an IT administrator, but also performing HR role. But is also connecting with the insurance providers in the private sector. You will have other person who has a clinical responsibility, but also have administrative and program manager responsibilities. So even though the numbers will sound 20, the roles that different people performed has insights into different aspects of the program. So which was very useful. One, it provided insights from different perspectives, but it also allowed to cross-validate information coming from different key informants. So in total, there were 20, and the main focus was to understand how the workflow, the data collection process, and the systems were working in that setting to enable decision-making for the stakeholders, primarily from the providers and the program manager and administrators. The purpose of including a patient was to validate whether the process that was explained by the stakeholders also aligned with how the patient experienced that flow in the hospital setting. So patient was a respondent to validate the information that was being generated through the other stakeholders in this study. So these are how the research questions were mapped with the specific questions in the tool, and you'll see that the tool has the key informant to guide has specific question addressing the 6 research questions aligned with the 3 research aims. And a qualitative data analysis was conducted, and you can see here an interactive model that comes from Miles and Haberman. And this process was, I would say, an iterative process as you started conducting data collection with one. The information that came was also informed what information, additional information will be required from the next one, or if there will be adaptation of a probing question that will be needed with the other stakeholders that were working in the same hospital setting or in the same program setting. So it was, I would say that it's a continuous collection, analysis, condensation, what you call summarizing and then going back to the next stakeholder. In few cases, there was a follow-up conversation that was needed to just understand and validate whether the process that was described by the informant was accurately captured. So before I go into defining, I'll say that when the data was collected, keeping in mind that the language differences were there, both English and Hindi, so the tool was developed in both. And both the English and the Hindi version were tested with a small group of people outside the study context, the people who are not participating in the study. And also when the data was collected in Hindi, it was translated in English and with an independent researcher working with me. And both the researcher, coding all the 20 interview transcript independently and then having a group meeting to discuss where the variations were and what were the reasons before coming to a consensus on what that coding may look like. Because of the language difference, it was not possible to divide the 20 transcripts 10 and 10. Both the researcher has to look at all the 20 transcripts and then look at. And qualitative analysis software tool was used, of course, support from the Ordam Institute to understand whether the approach that was followed allowed ensuring data quality and the proper way of coding and interpreting the results that I'll be sharing now. So this is the first theme that we talked about, the factors that favor or hamper. So what exactly came up? These are some of the key factors that appeared in the study. Leadership support and coordination, keeping in mind that there are multiple organizations, both at the state and national level. Even within the hospital, there are multiple entities that are involved in health IT initiatives. The budget and decision-making authority, they vary depending upon which level in the healthcare system you are. For example, if you are at the clinical level, you may have very limited authority to make decision based on what budget is made available to you. The approval process still goes up to the higher level. Also, the budgets are framed annually in general. So if you have a need additional or you want to have flexibility in a line item, the approval processes are cumbersome. They take time. Data collections are siloed in terms of what gets collected in the pharmacy and the lab by the clinicians, both for inpatient and outpatients. In the emergency department, they're all captured most of the times in multiple systems, both paper and electronic. Sometimes they're connected, sometimes they're not. And in this case, there was a legacy system being used, which was provided by one of the vendors almost 16 years ago. So you can imagine there's a legacy system for which you don't have even the source code to really make any change. So the only thing you are doing is a pro bono effort, that you can do to support a system that is not supported by the one that who created it. So that poses another major challenge, which also means that people who understood the technology, which is 16-year-old, are not many. So there's a very limited skill set that's available. At the same time, there are other systems that are being implemented and introduced by private sector players, also the state and national IT agencies and health departments. So you have the same group of people who need to work across multiple platforms and technologies, and not necessarily your trainings and workforce skill set are aligned with it. And keeping in mind that there's always a shortage of skilled workforce, and especially health IT workforce, apart from the clinical providers, it becomes even more cumbersome. So IT education and training gap was also an important barrier. And the way the systems are designed, and I'll show you how users perceived it, that it was not necessarily designed how the providers will use it. It was designed how the creators provided it, and you don't have much option to customize or change anything. You'll have to use what is available. So it's a challenging that you'll have to modify your workflow to meet the workflow of the system and not the other way around. And here is just, to showcase you the interorganizational linkages that exist. Some of them are, like formal, some of them are informal, but you have to interact. So you have a national ministry, which has multiple departments and units that run program. If you just look at the Ministry of Health in Indian context and in many other countries, you will see they have multiple IT programs that are run through. They all have certain requirements. They come from a federal mandate. They are tied up to a certain program. You are supposed to report data, but they don't always have necessary technical support aligned with it. And at the state and the hospital level, you may not have necessary workforce to feed data into all these multiple systems. They're not necessarily coordinated with each other. That means they can be developed on different technology platforms. Some of them are good, and they have been there for a long time, but they get replaced when a new system comes in, and which is a priority for the government at the time. So this is just to show you a different linkage between state level agencies, national level agencies, both program and IT agencies. And I think just by looking at the visual, you can see the complexity of information exchange that might be required And sometimes the information exchange may be only one way, coming from the state to the hospital, not going the other way. With certain departments, in other cases, you are expected to also share that. And this adds up to coordination and information sharing, which is always a challenging. I think there is enough evidence that suggests that governance, when it comes to the countries, is always challenging, but a critical factor that determines how health IT implementation, or in general, HIS implementation, is influenced in a country context. So that was looking at, from the national perspective here, look at the state tertiary care hospital, the state and public health program, and then how the medical education and IT agency, they all interact together. Keeping in mind that this is a tertiary care hospital, you have also educational responsibilities, even though the focus was only on the service delivery side or the practice side of it. It's very difficult to isolate that part with the educational responsibility of the providers, because they are involved on the both sides. So that adds another complexity when it comes to coordination and management within the hospital, but also how they interact with different agencies at the state and the national level. So here are some of the quotes from the informants, and you'll see there are programs which pays for maternal child health delivery. So child health, birth, both at the institutional facilities, but also at home, and they're covered. They're also covered in other programs, but how they get coordinated at the hospital level is primarily at the people who manage those programs. So there are guidance, but I think they also have their workarounds to ensure that if one program is paying for the expense, the other is not, and they make sure that they don't duplicate. So it's basically their own coordination, because the data gets reported in different systems. They have different processes. They have different entities that they report to. Still, there is an informal coordination there, but keeping in mind how fragmented their systems are, there's always a possibility of error. And I mentioned about a legacy system, which you can see that is always a challenging. That was highlighted by one of the key informants. But now they are working with the state IT department to come up with requirements for a new and advanced hospital information system. So they're working on a procurement. Hopefully that will happen in the next year or so. It depends on the timeline. And again, one of the factors that I mentioned earlier, the authority to make financial decisions is always limited as you go down the chain. So you can see that the responsibility for clinical care and service delivery increases as you go down the chain up to the facility, but the decision making when it comes to financial decisions does not relate to that work responsibility. It goes upwards in that sense. Now, the second aim was on the information needs and data systems and workflows. And what came up, you'll see that the federal government agencies, in that case, the Ministry of Health at the national level, is driving adoption into digital systems. That's in general. But again, you look at the states, especially if you go in the southern states or the western state, they have their own capacity and resources. In the world of maturity, we'll say they are relatively more mature than some of their northern and eastern counterparts. So you'll see that difference. But still, federal government has a strong and important role in this domain, especially now with the digital health mission. State IT and health departments, when come, they have limited role, and depending upon which state we look at, in this state, we'll say it's a limited role in that sense. Even in the state IT agency doesn't have many people who look at, they only have one person who looks into the entire health IT portfolio, who is expected to manage all the health IT initiatives that come from the federal government and supposed to be implemented in state, but also all the IT initiative that state wants to implement at the state and at the district and other levels. Most of the times, healthcare providers, they do not have an active engagement in the development of health IT system within the hospitals. And providers who have administrative role, they may have some role, but other than that, most of the providers do not have any role, and they will always say, why don't you talk with the HIS department, or you should go and look into private hospitals, how they are doing, if you really want to learn how health IT is being introduced in the hospitals. And as you can see here, even though this focus is on maternal health in a hospital setting, there are certain guidance that apply to the hospitals as well, even though they're national guidance. This is an important distinction here. The states can have their own guidance when it comes to health. still there are certain aspects where both state and national level entities follow. And this is just one example where maternal health was applicable here, and they received funding and technical support from the National Health Mission and the national government agencies to implement those programs. And as part of that, they can introduce digital systems, so they have the freedom to do it. It's up to them whether they can plan it and then, of course, get it approved. It's also important to highlight here that while this hospital in this case and many others are struggling to come up with a hospital information system, the national IT agency, what we call the National Informatics Center, they have developed a hospital information system. It seems from outside a very good system with different modules, but it's a very centralized, developed, controlled. So if you want to adapt and customize, it can take a long time, and you may not have the flexibility to customize to your needs. So that's another limitation. And I will show that that was one of the gaps highlighted by the participants, that we do not want a system that does not really meet our needs, and we are not able to customize it for what we would like to get it done in our case. So that's an important thing to do. There is a system, it's being promoted, it comes with IT support and necessary training, but still the buy-in when it comes to the district and the hospital is not very high. At least in this case, it didn't happen. In this hospital, they simply rejected and refused to say that we are not going to implement because it does not fit into our requirements. And the other important thing that they asked was, can it align with the legacy system that we have? Now, all those who work on health IT system, they can easily understand that a system which is 16-year-old without any source code, how challenging it can be to align with that legacy system while you are trying to promote a new one. So looking at the data system and workflow, I think, and I mentioned earlier, it has a mix, electronic and paper-based, depending upon which unit you go. The billing is the one that is mostly electronic. But when you go to the provider interactions, that's largely paper-based, and that's how they get it stored. And many times different forms gets introduced based on the need by the administrator. They're not normally, not necessarily a standardized form and implemented through a proper training, but because an immediate need, an important need, they many times introduce that kind of form. So those processes are ad hoc. And that makes it challenging to how you manage. So here is one example where one of the key informants mentioned about once a patient is admitted, the steps that they follow to capture the demographic and personal details into electronic system, but then most of the clinical aspect, they get captured into multiple paper-based registers, which are not often captured in the electronic system, even though a summary report is included into the different reporting formats that they're supposed to require. At the end of the treatment, when a patient is discharged, it will be a paper-based patient record that will be that is normally submitted to the medical record department. So you can find a patient record in a paper form, which is stored. And what was interesting finding was they had those paper records for the last 30 years. So you can imagine the pile that they may have now. Whether they're still in usable format is something that this study didn't focus, but they do have a way to collect and store it. And that MRD department is responsible for submitting the report using the ICD-10 codes for national level reporting. So they do have that kind of awareness, but only for a limited purpose. Here is how the current relationship is when a patient comes in, where the registration happens. You'll see then the patient, interacts with the provider, and depending upon what the recommendation is, you will go to either the lab or the radiology or the pharmacy, or you may get, admitted to the hospital, depending upon what the healthcare need is. So you can see that a patient, is moving from one point to another, depending upon what the care is. And if the systems are not connected, I think we can just understand how complicated it can be when it comes to patient care and looking at their past history and other records. So this is how the current relationship was. And in terms of reporting, of course, the hospital is expected to report to multiple programs based on different reporting requirements, both at the state level. And all these systems are, so state health authority, which primarily looks at the insurance part of one of the national insurance initiatives. National Insurance Program has their own IT system centralized, so you are expected to report on that one. But they also have some of the programmatic requirement that you are supposed to report to another state level entity. And in general, they coordinate with each other, but is it very structured? Is it standardized? Is there a standard operating protocol to that happen? That's not always clear. And at least in this case, there was no such standard protocol that was available. And information needs, so like I mentioned here, so people who are involved in implementation and monitoring, there are stakeholders who are more in the care coordination, but also administrative operational decisions. People who are tracking financial incentives to the beneficiaries, they have their own reporting requirements, and then patients who need their records for referral services or for follow-up visits. So these are different needs that the stakeholders had that was reported in this study. And here, as you can see, one of the important information needs was that one team needs that record simply to report to the state health mission as part of their reporting requirements, because they are tied up with financial incentives. So one, you want to show the accountability, but you also want to show the scope and the scale of the beneficiaries who are able to access those services. And then again, you can see all these different admission, billing, collection, investigation related aspects. These are done through an emergency visit, but also through the routine visits, but they get captured separately. And if the patient needs to be shifted from one unit to another, these records play a very important role, but often they're not in one consolidated form. Finally, coming to the third one, where we talked about the work model. So here is the process that was followed, of course, looking at the literature, the framework that I mentioned earlier. And then, after collecting the data, a draft model was developed, and then it was presented back to two of the key stakeholders, one at the state and one at the national level, people who have been familiar and been working in the maternal child health domain for more than 2 decades. And after they review, the final version was created. So you'll see that architecture that I'll present here. But prior to that, these are some of the essential design requirements that were highlighted. You can see, that how the referral, admission, and discharge and transfer processes were the critical aspect that were highlighted across, most of the stakeholders. Also, the insurance and the billing part was very critical, and tied up with most of the healthcare services that were being delivered. And starting minimum data sets. So across the studies, what stakeholders highlighted, especially the providers, that there are certain data that we require on a routine basis. So if you can standardize that, that will be very, very helpful. But also the workflow. And I think the workflow, after collecting the data, there was a standard workflow that can be created, both for the clinical perspective and the sharing the data within the different unit, but also to feed into the reporting process that they have. And given the mandate that is coming up under the National Digital Health Mission, the states will be expected to create registry for both clinical care and research. And this work can also feed into that. And this was highlighted also by one of the key informants, because this is hospital tied up with a teaching and research institution. They also have research requirements. So based on those desired requirements, here is what the model proposed. As you see on the left, when in the patient encounter, most of this administrative and the clinical data is generated, which can be captured through electronic health record network that basically captures data. So many of these pieces are there. Some of them are legacy, some of them are recent ones, but pulling them together over network into a single record for a patient is going to be very important to deliver coordination, to coordinate the care perspective, but also the health ID that the federal government is creating, the health ID registry, which is going to enable health data exchange across providers across the country, which will be a key factor in the interorganizational data exchange, both hospitals network that exists within the public health system, but also outside the public health system. And then if they're able to put this, this model that allows them to do it, and I think the new system that they're envisioning will be able to achieve most of these goals, to aggregate the data in a de-identified way and feed into the most of the operational and the reporting requirements that they have at the state level, but also to the national level. And I see that probably it's not visible here somehow. So that's how they can not only use it for care, but also for the aggregate data reporting requirements that they have, and the health ID registry that is being created will allow them to exchange data within and the public health, but also outside the public health network. And here is what one of the key informants said, that they have the data. It's not that they are not collecting the data. If we are able to connect them, I think that's the main point that's coming up. So in one way, it's validation of what the study was trying to accomplish, that if you are able to connect them, it serves not only the clinical purpose, but also allows them to use it for research purposes and the reporting purposes. So this is something important to mention here. And the proposed model basically allows to go for the clinical care, but also for program management, right? At the hospital level, but also at the state and the national level. So it feeds into the reporting requirements as well. At the same time, it will improve efficiency when it comes to data collection and reporting. So you can see here that if you have an electronic health record that's is under planning, there's a My Health record, which is basically a personal health record that is created by the national agencies, and there is expectation that you will report your data. As a patient, you can store your data, but what is happening currently is I have to collect multiple reports, convert into PDF, and then go ahead and upload it. But if I have my patient record in one single place, I would be able to keep it or and store it. But also it shows up how complicated the landscape is when you have your record being organized by another entity and your personal health record being managed by another entity, and they both have different requirements from you. Also, when you are so GSI here is what the Safe Motherhood Child Delivery Program, what we call Janani Suraksha Yojana. So basically, you get paid for institutional child delivery there. So you have a reporting requirement there. The next one, the PMJY, that's also the is the largest national program where you get paid for your hospital cost there. That's also tied up here with your records. So your records are used to verify your eligibility and what gets paid, what qualifies that to be paid. So these are packages which has specific cost associated with. So depending upon where you qualify, they get paid. So you can see that how a patient's electronic health record can also feed into that. And of course, then the aggregate data feeding into multiple other systems that exist at the state level, but also at the national levels. So this is also how the reporting can influence. And I mentioned about the registry. So there is a national effort to create a doctor registry, a health facility registry, a health ID registries, and many of the states are taking initiative. So to feed into those registries, you will need the electronic data that can be used to feed, not only feed into those national registries, but also some of the disease and the public health registry that you are expected. And given the COVID situation, there is a growing focus in many of these hospitals, including this hospital, to strengthen their clinical registries, not only for disease surveillance, but also to guide the public health decision-making process. So this model is allowing them to serve in all these different requirements from both the research at the state and the national level. And here you can see that how they can connect with a research registry that they can build it. And as I mentioned, this was one of the key findings, not key findings, I would say, but this is one of the important highlights that came up. And important in the sense that this was not a focus of the study, but given that the hospital is associated with a research and academic institution, research is an important priority. And this model can also feed into the research registries that they're going to command. And I'll quickly mention, the limitation that we highlighted are very much aligned with a lot of literature available when it comes to leadership governance, decision-making, the processes. And even now, I think there is still a research being conducted, how the policy environment, how the infrastructure, the data security and confidentiality aspects, and the implementation adoption of standards influence inter-organizational data exchange. And there was a study published in December last year, which looked at 6 countries, both including India as one of the countries, on what are the essential criteria for health information exchange. And electronic health information is one of the things. The governance and privacy policies is another important criteria, and the leadership support and coordination was another key criteria that was considered. So as you can see, the findings are very much aligned with that research study, and it shows that how to operationalize a federated architecture, especially where the facilities are expected or the hospitals are expected to be the main point of care or service delivery unit. That kind of model will be an important contribution. So the recommendations that came up was that, one, we need to have a governing body. We also need to understand what are the different systems being implemented, what their scope is, who are the users, what data is being collected, what decision being made. In most of the cases, there is no record for such kind of thing. And also incentivize adoption and use of EHRs. So there are certain incentives available, and some of these insurance, a larger program, the registry program, the National Health Mission programs, they are available. They may also drive or incentivize adoption of standards and tools because they do allow flexibility to these hospitals. And then creating a central data strategy so that it feeds into not only the clinical care, but also from the research program management and the policymaking perspective. As of now, there is a gap on that side as well. And then, of course, building the knowledge and skill when it comes to using the available data and also the data that will be captured in Fuser so that people see a value in using the data and improving the quality of data, which is connected with how the culture of data use can be improved. And I'll quickly mention about the strengths. Of course, the qualitative design was appropriate here to allow looking into socio-technical factors, but also purposive sampling allowed to identify high quality interview. In certain cases, there are only few key informants who could have answered those kind of questions or has the technical knowledge. It would have been difficult even by expanding the sample size. And the virtual data collection in one way was advantageous because it allows to overcome the geographical barriers, which could have cost implications in other cases. So it came as a benefit, but at the same time, the sample size is something that I'll say it was a limitation, especially because just including one patient, even though it aligned with the purpose, is an important limitation. And also the study didn't focus on the academic and the research side, which will be something to consider in future. And single case study, which was appropriate for this person, but it does not allow a cross comparison with another case studies. And then, of course, missing the part to observe people in the real life was another important limitation. And inductive approaches has its own advantages. In this case, enterprise, there was no goal to develop or test any hypotheses or come up with a theoretical framework, so it aligned in that sense, but it can be expanded in future studies. So to conclude, the value of health data exchange is well understood globally in this case as well, and the electronic health information capturing is becoming global priority, and it's a priority at least in the case of India, which is moving far rapidly to expand it. And then a data exchange model can offer a common framework for stakeholders to engage and understand what are the requirements and needs at the different levels of the system, but also to understand that health data exchange is not a technical issue, it's more of a socio-technical thing that will require such approach to do that. And that's what is guiding the future research. So my current work is very much in the direction where I'm looking at the recommendation that I mentioned earlier, but also understanding what do we mean, by advancing capacity, when we will say that a country has achieved certain capabilities, both this process, people related, also technological aspect that they can do health information exchange or health data exchange within the public setting or with the private setting. How we'll measure that? So that's another important area of research, and fortunately I'm conducting that kind of work as well. And also, this will be something to consider in future, and hopefully there will be other researches as well. How does really, health data exchange improve the quality, reduces cost, and increases patient satisfaction? And this can be something that in the World Health Organization, when they're looking at their dynamic digital health maturity model, where they're looking at the value generation from the patient care perspective, might throw some light on how this can be achieved. So thank you very much. Sorry, I've taken more time. These are some of the references, and thank you to my committee, of course, and my friends. Some of them are here on this presentation as well, and to the CHIP team as well. Thank you so much.
Thank you so much, Manish. That was an amazing presentation. I'd like to open the floor for just a few minutes if anyone has any questions or any clarifying points for Manish.